Today's video is about the cardiac cycle, the nervous supply to the heart, and we expect also talk about the blood supply and the layers of the heart. Considering that this is our heart, in anatomy, you will be probably looking at someone else's heart. So, this will be the left of that individual, and this will be the right of that individual. Implying that this side is the left side of the heart, and this is the right side of the heart. These two are indicating the pulmonary veins. There are meant to be 4, but we have only showed 2. We have 4 pulmonary veins coming, or rather carrying blood back to the heart from the lungs for oxygenation. This is our left atrium. Here we have our mitral valves. They can also be called bicuspid valves because they have 2 cusps. This is our left ventricle. This is the aortic valve, or it can be called the aortic semilunar valve. And this is the aorta, which is carrying blood to the systemic circulation all over the body. When we go to the right side of the heart, this will be our vena cava, the superior vena cava, and the inferior vena cava. Superior vena cava bringing blood from the top part of the body, and the inferior vena cava bringing blood from the lower part of the body. This is the right atrium, tricuspid valves, tricuspid, three cusps. The ventricle, our pulmonary valve, or pulmonary semilunar valve, our pulmonary artery, further bisecting into 2 and going to either sides of the lungs. In case we take a situation where you have an healthy heart and it is professionally removed out of your thoracic cavity and placed on the tray, the surgeons would probably see that heart pumping. It will continue pumping even when removed out of the body, even when cut off its nervous supply. It will continue pumping for some time. This is a great indication showing that the heartbeat, the initiation of an heartbeat, is not dependent on the nerve supply nor on hormones, but it is dependent, or it originates from the heart itself. It is intrinsic to the heart. The heartbeat originates from the heart itself. It is intrinsic to the heart. This is possible because we already know that this layer of the heart, this one, the one I'm shading, is our myocardium. And this myocardium is made of cardiac tissue. Cardiac tissue is specific to the heart alone. It is not found anywhere in the body other than the heart, the muscle of the heart, the myocardium. That's where we find our cardiac tissue. And this cardiac tissue is highly specialized. It is highly adapted to the functioning, or rather to the pumping action of the heart. You notice that this cardiac tissue, if you were to consider its shape, each of the strands of the cardiac tissue, each of the cell, has a nucleus. And not only a nucleus, it also has numerous mitochondria. The nucleus is actually going to be controlling so many activities within our cardiac cells, for example, even the contractile activity itself. But the mitochondria, they are numerous because it's specified to provide energy. They are power centers, power cells, the mitochondria, to provide energy for the contractile activity of these cells. These cells are highly branched and they are connected to other cells directly. The plasma is linked by this forming these discs, which we shall call intercalated discs. These discs, this implies that if a nerve impulse is initiated or targeted to one of the cardiac cells within a sheet of cardiac cells, it will not end on only that cardiac cell, but it will move throughout, it will be distributed throughout the whole tissue, the entire cardiac tissue. Because at the intercalated disc site, electrical impulse can easily cross. Not only that, this myocardium is highly supplied with blood vessels. It's highly supplied with blood vessels to nourish it with oxygen, which is to be used in the formation of energy, ATP, in the mitochondria, which is essential for the contractile activity of the heart muscles. And these blood vessels supplying the heart are known as the coronary arteries. The coronary arteries are actually originating from our aorta, the ascending aorta, as the aorta is ascending up before it makes the aortic arc. These blood vessels will branch off it, and we shall consider them as the coronary arteries. And they will distribute themselves all across the heart, both on the left and the right side of the heart, nourishing the muscles of the heart with blood, which blood will contain the nutrients and oxygen essential in energy formation. Now, the main importance of the video was specifically about the cardiac cycle. We can now talk about the cardiac cycle. When we look at our right atrium, in the right atrium, we have specialized cardiac, we have a set of specialized cardiac tissue. Specialized cardiac tissue. Surround here. We have a set of specialized cardiac tissue, which is electrically, intrinsically unstable. It is electrically, intrinsically unstable. This site here, site made of specialized cardiac tissue. And it is known as the SA node. It is known as the SA node, meaning the sino-atrial node. The sino-atrial node. This site here, it undergoes depolarization and again repolarization at a rate of around 90 times a minute. 90 times a minute. Resulting into an electrical impulse. Releasing an electrical impulse. So it can also be considered as the heart pacemaker. So the sino-atrial node is the heart's internal pacemaker. It determines the rate at which the heart is pumping initially. by it undergoing depolarization and repolarization at a rate of around 90 times a minute. But this is not the only site in our heart which can undergo depolarization and repolarization. Rather, it is not the only site which is electronically, intrinsically unstable. We also have another site which is just located in the area, it is located in the cardiac septum, in the area between the atrium and the ventricle. Because it's located in the area between the atrium and the ventricle, it is known as the AV node. AV node. AV node, AV, it's meaning atrioventricular node. And we are already aware why it's called the atrioventricular node, because it's located in the area which is between the atria and the ventricle. So, atrioventricular node. It is also electronically, intrinsically unstable, but its rate of depolarization and repolarization is far less than the rate of depolarization and repolarization of the sinoatrial node. It is less. Therefore, its effect is kind of negligible. It's kind of smaller. It's kind of smaller. But these two are specialized. They are made of specialized cardiac tissue, which is electronically, intrinsically unstable. It releases electrical impulse, electrical nervous impulse by depolarization and repolarization. But that's not the only specialized cardiac muscle we have within the heart. We also have pathways within the heart, which are specialized. They are cardiac tissues specialized for conductancy or conducting electrical nervous impulse. And there are three pathways moving electrical nervous impulse from the sinoatrial node, distributing it all over the atria, or rather the atriums, and finally also taking it towards the atrioventricular node. So we have our uppermost pathway, which takes the impulse, the electrical nerve impulse, to the left atria, and this one is known as the anterior conducting pathway. The anterior conducting pathway. We have another one which goes up just such a region. It is known as the middle conducting pathway. Then we have the final pathway, which is known as the posterior conducting pathway. The posterior conducting pathway. These pathways keep on branching as they move. They have branches on them. This is specifically an adaptation to ensure that all the cardiac, or rather faster distribution, to ensure faster distribution of electrical nervous impulse generated from the sinoatrial node, our heart pacemaker. When these conducting pathways reach at around this point, they start moving towards the atrioventricular node here. So our atrioventricular node is acting as a collecting node. It can also be called a collecting node. It is collecting up the charge. It is collecting up the charge. So when this depolarizes and repolarizes again, it will cause the atriums to contract. But this charge, the electrical nerve impulse, is not actually going to move the electricity to the ventricle. Rather, move the electricity to the ventricular myocardium. It's going to be restricted to moving the electricity to the ventricular myocardium by a ring made up of fibrous tissue, mainly the collagen, which is made from the valves, and it can be called the atrioventricular valvular ring. Atrioventricular valvular ring. It is called the atrioventricular valvular ring. Why? Atrioventricular because it is separating, it is between the atrium and the ventricles. Valvular because it's specifically made of the valves within the heart. Ring because it makes a ring shape around the heart, creating an insulation between the atrium and the ventricles. Hence, the electrical nerve impulse does not move directly from the atriums to the ventricle. It is restricted, and it all has to pass through the atrioventricular node in order to reach the ventricles. So the atrioventricular node is acting as our collecting node. And since it's acting as our collecting node, it will actually take some time for it to collect all the impulse. It creates some delay. As the impulse is being collected from the atrium to the atrioventricular node, there is a delay in time of around 45 milliseconds. 45 milliseconds. And these 45 milliseconds give enough time for ventricular filling to be completed. They give enough time, the 45 milliseconds required for complete collection of the electrical nerve impulse from the atrium to the atrioventricular node, give enough time for all the blood to move from the atrium to the ventricle, a term considered as ventricular filling. Ventricular filling. Ventricular filling. Now, from this atrioventricular node, we have specialized cardiac tissue, creating pathways which move or rather distribute the electrical impulse from the atrioventricular node all over the ventricles. So we shall have this specialized cardiac tissue. It is called the bundle of His. It used to be called that, the bundle of His, depending on the one who discovered it. But its real name is the atrioventricular bundle. Atrioventricular bundle. This, the atrioventricular bundle, it moves and it divides into two. As it moves towards the heart's apex. In fact, this is something one has to note. The lower part of the heart, this part, is known as the cardiac apex. This one is known as the cardiac apex. Whereas this side, where the blood vessels are attached, it is known as the cardiac base. It's known as the cardiac base. Upper part. It's known as the, so this is the cardiac base and this is the cardiac apex. So to continue, so the nerve impulse will move through these atrioventricular bundles down the way to the cardiac apex. Where we shall form Purkinje tissue. It's also a specialized cardiac tissue, specialized for electric conductivity, specialized to move electricity, to conduct electrical nerve impulse, known as the Purkinje tissue. This distribution, the smaller distributaries of the atrioventricular bundle are known as the Purkinje tissue. So, Purkinje tissue are known as the Purkinje tissue. So they will come and distribute the nerve impulse all across our ventricular myocardium. all across our ventricular myocardium, or rather ventricular cardiac tissue. Now, the main indication of this electrical nerve impulse being directed to the cardiac apex by the atrioventricular bundles, further by the Purkinje tissue, is to make sure that the contraction of the heart is coordinated. The atrium, during heart contraction, the atriums contract first, pushing blood to the ventricles. But in case the nerve impulse had been allowed to cross directly from the atrial myocardium to the ventricular myocardium, it would actually cause uncoordinated contraction of the heart. Because the contraction will be from heart and it will be just continue downwards, forcing blood again towards the cardiac apex. Blood will just remain here in the ventricles. But because of this specialization of the heart by formation of the atrioventricular valve ring, which is electronically insulative, it does not allow electrical nerve impulse to cross it directly, the heartbeat becomes more coordinated. The atrium contracts first, pushing blood to the ventricle. Then the nerve impulse is restricted from going to the ventricle. It is all collected by the atrioventricular node. It is directed towards the cardiac apex by the atrioventricular bundle and the Purkinje tissue. Then the contraction of the ventricles is initiated and it starts from the bottom. It starts from the cardiac apex upwards. So the ventricles contract from the cardiac apex upwards, hence pushing blood through our arteries. That's the pulmonary artery and the aorta. Now, during the ventricular contraction, when this nerve impulse is distributed towards the ventricles, it will reach the cardiac base first. So the cardiac base is going to contract upwards, and then these walls, the myocardium, the side walls, will contract inwards. So the contraction is going to be upwards and inwards. Upwards and inwards. At the same time, there will be some cardiac twisting. The heart will twist. It will twist. It's going to springs twist. And this is very essential. The twisting is very essential because as it twists during the ventricular contraction, it stores energy, which is going to be so helpful in the ventricular feeling in the next cardiac cycle. In the next cardiac cycle, which is going to be essential in the ventricular feeling in the next cardiac cycle. So as it springs back after storing that energy, springing back during ventricular relaxation, springing back, as it springs back, it will aid in ventricular feeling in the next cardiac cycle. So that's our summary. So we can now try to see how the blood is going to keep on moving as the contractions move on. So blood comes from the body, that is the lower part of the body, and the upper part of the the upper part of the body and the lower part of the body. When it's deoxygenated through the superior and inferior vena cava, and it goes into the right atrium, reaches the right atrium. At the same time, blood is coming back from the heart, from the lungs, when it is oxygenated through the pulmonary veins into the left atrium. So we are having atrial filling. Now the atrium are going to contract first. When they contract, they will push blood to the ventricles. After pushing blood to the ventricles, at that point, our ventricles, our artery valves, or they can be called the semilunar valves, these two, the pulmonary semilunar valve and the aortic semilunar valve will be closed. Then we shall have the ventricle contracting, the ventricles, so it will push blood, so it contracts inwards and upwards, so pushing blood across these semilunar valves to the lungs and to the body. And that will be a complete cardiac cycle, complete one. We shall explain it further in the next video using graphs, which will illustrate out what exactly happened to the valves, to the pressure in the ventricles and the atrium, what happens to the different nodes in terms of electrical charge. We shall all see that in the next video, which is going to be about the ECG, the electrocardiogram. So that's our simple summary. Thank you very much. I'm Clinician Birungi Roven. You can call me Clinician Rovenance.